Well, thank you very much, PK. And I think, well, I will not only speak about drug-coated balloons for critical limb ischemia. I think when we treat critical limb ischemia, as we heard and as we all know, very frequently we are dealing with both inflow disease in the femoral artery and below the knee obstruction. So I think the real treatment starts in the SFA and affects really a variety of vascular segments. And if what we have in terms of drug-coated technology, I think it's very clear. We have drug-coated balloons, which currently catches most of the interest, clearly. We have drug-eluting stents, and then we have some new drug delivery concepts, and we also have drug-eluting scaffolds. I don't want to address that, but for the sake of completeness, I think we have to mention that also these technologies do exist. I think, as I said, very clearly, particularly when we start treating inflow lesions, DCB technology is very high on our radar. There are multiple trials which show the proof of concept, and there are also important large pivotal studies which have been addressed by Dr. Fanelli extensively, which were demonstrating that DCB technology is very capable of improving the restenosis rates and the durability of our reconstructions in the femoral area. But I think we have to be very clear that for all these data sets and randomized trials, there were no Rutherford 5 and 6 patients involved. So in fact, these data are not existing. And we also have very encouraging data on longer lesions, C&D lesions, from what's called the global registry, for instance. And I think it really shows that we can be very effective with DCB also in long lesions. However, even if it's called global and we claim that these are all comers, I mean, they are in fact not all comers, because again, CLI patients were not part of these analysis. So we don't have any evidence. What we know, however, from these randomized, particularly from these studies looking at the long lesions, is that the more complex the lesion gets, and I think that's what we typically also see in CLI lesions, the longer they get, the more calcified they get, the more likely we are not able to achieve a sufficient result with DCB technology only, and we need additional stenting. So the question could come up, of course, whether drug-eluting stents are a better option to treat inflow disease in CLI patients. But I think, again, we know that the data are very good and showed a lot of durability out to 5 years. But also in these trials, CLI patients were largely underrepresented and were really not looked at specifically. So I think in reality, we don't know exactly how drug-eluting technologies can help us to treat inflow lesions in CLI patients. I think the real experience, what we have, is that usually these lesions are very complex, and even with conventional stents, sometimes we cannot get good results because calcification is a very frequent challenge. That's why I believe that the device which we've just seen here in the live case, like the Supera stent, has a lot of room here to really help us to better get a better inflow opening in those patients and guarantee inflow. So I would summarize for the inflow treatment, I think there's really no proof from randomized clinical trials or large studies that DCB can be helpful in CLI. There's also very limited evidence for drug-eluting stents. Also, probably these devices have been used in many CLI patients in the past. I think what's really key here is that we need acute vessel patency to achieve a stable inflow situation into the femoropopliteal tract, because we really want to make sure that these patients don't reocclude 2 days after our procedure. Since we are looking very frequently at very calcified arteries, which is a important challenge in these diffuse vascular pathologies, I think, for instance, devices like this biomimetic stent technology may be frequently indicated. Well, so far about the inflow problem. The real problem, of course, starts below the knee. And again, if you look back on what's available in terms of evidence on drug-eluting stents, we can say that there are good data, as you know, for drug-eluting stents, coronary stents in the below-the-knee area. There have been studies comparing them with bare metal stents or with plain balloon, and all these 3 trials, the Yukon, Destiny, Achilles trials, showed significantly better results for drug-eluting stents. However, the problem is that they are very limited in their lengths, as you know, around 3 to 4 centimeter maximum length. So typically they can only be used for very focal disease, which is not the typical disease pattern in CLI patients. I think what is really typical is that we are dealing with long occlusions of the infrapopliteal circulation, typically involving all 3 below the knee arteries. And I think here, I think it was very clear that only balloon-based technologies are showing a promise to be helpful. So what about DCB in the below the knee area? I must say that this is really an area where we don't have a conclusive answer at the moment, and we have different data available, some positive and more frequently negative data. To start off, I would like to mention that our initial experience in Leipzig, when we started very early comparing our DCB results below the knee with historical results from our own institution, indicated actually that at a very early time point, we did angiographies at 3 months follow-up, where we know that the restenosis rate was already very high. We've actually seen very impressive initial advantage of the DCB technology, with better patency and reduced TLR rates. Similar results were also coming from Italy, an early series from Dr. Listro. He looked in the debate BTK study at the 12 months outcome and assessed by angiography, and also showed a significantly lower restenosis rate for the DCB treated patients. However, it was really kind of frustrating for us and to other investigators to see that in randomized clinical trials, namely the IMPACT DEEP trial, these results could not be reproduced. As you probably know, there was really no difference during the angiographic control at 1 year, and there was almost a potential safety signal, which were actually a slightly increased rate of major amputation, which eventually led to the withdrawal of the device from the market by the manufacturer. And we've also seen in a small study from Biotronic that also in their study there was no significant advantage seen with DCB in the below the knee area. So I think we are still in a phase to fully understand these results. And I don't want to discuss that in detail, but at least one of the observations was that if we look at the restenosis rate, specifically in the IMPACT DEEP study, we can say that if we only look at the plain balloon arm, the PTA arm, we must say that the binary restenosis rates observed in the study were really surprisingly low. So that means the control group did perform much better than expected, particularly if you consider that the lesion length was around 8 centimeters. And in all the DES studies with much shorter lesions, we actually had seen much higher restenosis rates. So that's probably indicating that there was a certain selection going on here in this trial. And also if you look at the clinical endpoints, the death and amputation rates, interestingly the PTA arms, both in the IMPACT study and the Paseo Biotronic study, did do very well and actually much better than in these I think even more selected patients with the short lesions in Achilles and the Yukon study. So that's an observation, and of course it's unclear to which extent these trials incorporated patients which represent our real-world challenges. What we also have to recognize is that there were really very first-generation coatings used during these trials, which had the issue that there was a more than wanted deliberation of small particles, and Renew spoke about this significance. So it's important to know that there are more advanced devices like the Lutonix device with a better coating available. This is currently, as you know, under investigation and a large randomized clinical trial here in the United States and globally, looking at a large proportion of patients with CLI disease in a randomized fashion, 2-to-1 randomization between the DCB and the balloon arm. Just to mention, this device is commercially still available in Europe, and we looked to get some reassurance about the safety at our own data, 220 limbs in 208 patients treated, a lot of them with diabetic, and a lot of them with very long lesions, 24 centimeter cumulative DCB lengths. And what we've seen actually was a very good freedom from amputation in our analysis, and also a good and encouraging freedom from target lesion revascularization out to the 12 months time point. So this is single center retrospective data, but in a way reassuring. Just to mention, there may be other ways to deliver a drug below the knee. One interesting concept, I think, is the bullfrog, which comes from Mercator. You can see here a balloon with a little needle which is exposed during the inflation and actually allows injection of active agents into the subintimal space. In the current analysis, I can't advance that here. In the current analysis, we are using actually dexamethasone as to interrupt very early with the cascade of inflammation. You can see this is currently under investigation in randomized trials in the United States and in Europe. There were some encouraging data from the so-called DAN study about this application in the SFA, and currently there are 2 trials, one with the dexamethasone application after atherectomy below the knee, and one after PTA balloon below the knee in Europe. So I think, in summary, I think there's still an unmet need for improved durability in the below the knee area. I think drug delivery via balloon-based solutions may still be the most realistic approach. The Lutonix clinical trial program is ongoing, and I think it's interesting to look at alternative ways of drug delivery. Thank you very much.